So my name's Josh Rinker. I'm a psychologist with VA Portland and also the Secretary Treasurer of the VA section of Division 18, Psychologists in Public Service. I'll be monitoring the chat today throughout our presentation, along with our speakers. So please be sure to leave any questions there and we'll get to them as time allows. Before I introduce our speakers, the VA section would like to acknowledge that yesterday, June 19th, was Juneteenth, and this date is being observed with a federal holiday today for only the second time. Juneteenth commemorates the announcement by Major General Gordon Granger of President Abraham Lincoln's Emancipation Proclamation to Galveston, Texas on June 19th, 1865. Although President Lincoln issued the Emancipation Proclamation on January 1st, 1863, Texas was the last Confederate state to announce the proclamation. Given our socio-political climate of divisiveness and efforts to oppress people, celebrating Juneteenth today as a federal holiday is especially relevant. The VA section hopes everyone is able to take some time to honor its meaning. It's now my pleasure to introduce our speakers for today's webinar, presented by the VA section of Division 18, Bringing Innovation Behind Locked Doors, the role of psychologists on inpatient mental health. Dr. Erica Carr is an associate professor at Yale School of Medicine and the Connecticut Mental Health Center. She's the director of the Inpatient Psychology Service and the Behavioral Intervention Service. Her interests include social justice advocacy and leadership, positive behavioral supports, recovery-oriented care, and women with serious mental illness. Dr. Jeff Smith is a licensed psychologist in Colorado and the section chief for acute and residential programs in the Veterans Affairs Eastern Colorado healthcare system. His interests and accomplishments include program development and evaluation, suicide prevention research with acceptance commitment therapy, creating trauma-informed systems of care, and leadership development. Dr. Carr and Dr. Smith, I'll hand things over to you.
Thank you.
Thank you, Josh. Erica and I are really pleased to be with you today, and we were laughing and joking as we were preparing that we really feel like we found a far-flung sibling. So I feel like I have a sister out in Connecticut who likes the same things I like and has a lot of the same strong passions for what a psychologist can be on inpatient mental health. So we hope to have an interactive, kind of organically unfolding talk with you today. Certainly we have content and slides, but we're looking forward to having you put your questions in the chat or respond to our questions and enliven the discussion in ways that make this a little bit more than death by PowerPoint and help us have what I hope is a dynamic and interactive presentation. Okay, Erica, I think we go to the next slide. So let's set the stage. We're aware that the inpatient mental health context may not be familiar to many folks. And so we wanted to talk about what it's like to be in an inpatient mental health unit. So of primary importance are, of course, safety and stability. Most inpatient mental health units are relatively brief windows in time with someone. There can be longer stay units and shorter stay units. Erica and I found that we're both on the medium to longer side, the VA with a little bit shorter length of stay. And LOS stands for length of stay, and utilization management are the letters for UM. And that indicates that there are some forces at work on administrative forces that may push us to work toward discharge in different ways. And so while there are some very common features with secure mental health units, such as the kinds of chairs you see depicted here, there are also a wide level of variability. But in general, these are fast-paced, cohesive, interdisciplinary teams, and the psychologist has to find their space and in some ways make their own mold for what it means to be a psychologist on an inpatient mental health team. Typically, those interdisciplinary teams are comprised of nursing and psychiatry and social work, as well as therapeutic rec. But it is often the case that a psychologist is not a core member of the team, but an add-on. And so we'll talk about how to make the most of this role, but also the fact that sometimes you are a core member of the team. I just returned from Roseburg, VA, where their psychologist is acting as the case manager for all patients and is certainly at the very center of things. So on an inpatient mental health unit, we have shared milieu. That means people are developing a little social network if they're open to it right there on the unit. There are unit activities and resources that offer as kind of tools for behavioral activation. We'll talk about skillful psychologists and how to use the tools on the unit to really drive recovery. Most inpatient mental health units nowadays aspire to be strengths-based and grounded in science. And Erica's going to do a great overview of what we mean when we talk about the mental health recovery culture and how to really be aligned with strengths and values of our patients. We also wanted to point out that post-discharge support systems may vary distinctly. In the VA, for example, we have a host of programs available to catch a veteran coming out of inpatient care. Same may not be true for community and other types of hospitals. Okay, Erica, next slide.
One of the things that's so exciting and is just, to me, something that makes it just an invigorating place to be is inpatient units are a place where you can really play a huge part in changing the culture. Back in the 1960s, long time ago, a lot of people know, and have seen movies about the way inpatient units have been, and actually the way some still are. And so it's a place where we can step in and actually play a unique role. Interestingly enough, these inpatient milieus with 20 beds where people aren't feeling the best and aren't in their most well state, with 30 additional people who are trained in all different ways with all different disciplines trying to work to support them, is not necessarily the easiest run place. So as you can imagine, even though everybody is well intended, it can be sometimes chaotic. There can be crises. People aren't feeling well. People may have been trained more in the 60s and other people are trained in 2018. So there can be a lot of changes and a lot of different personalities on the unit. And I'm not just talking about the people that are there to receive services. I'm talking about all of us working together. So naturally, it can be a place that we can come in and we might be actually really skillful and we can use all the skill sets that we're trained in. Obviously, we have a lot of different competencies that we're trained in, but some of the things that can be really helpful here are our training in good communication, working with different groups with complicated issues, things like cultural awareness, and problem solving. So these units that have all these different things occurring at the same time, with so many people trying to both live there and get well, and people trying to help them, sometimes have problems that we need to fix. So we can be very helpful in these. And sometimes we serve in formal leadership roles right there in the core of the unit, kind of like Jeff said. I'm actually in kind of a core position like that, and a really strong leadership position, which sometimes it is exciting, sometimes intimidating, and I just want to be like, well, I don't have the magic wand. But it's also an opportunity as someone who's trained from a socially just perspective to share that with the unit. And we're going to talk about a little bit more about some of the ways that we can share unique models that can really help these places grow and be places of healing. So next, I'm going to talk about one of these models that we really try to implement here, and that's trauma-informed care. You may have heard this, and you may have heard this word across your settings, but it's so incredibly important in inpatient settings. And I just don't see how any inpatient setting can be done well without some of this really strong training. And this is about how you run the services and system as a whole, not just like an intervention or one way of doing things, but how everything is done. How do we offer people things like safety, choice, working with people? How are we trustworthy with them? And then how do we empower people? And when we think about safety, we have to think about it in every which way you can think about it. If people are coming in and they have, some mental health diagnosis like schizophrenia or something else, but they've also experienced a lot of serious trauma that interacts with it, that makes them have much more challenges, they really need to feel safe there. So we have to think about how the very environment communicates safety or a lack of safety, which can be quite tricky when other people are in distress too, and there may be people telling you what you need to do. So how do we communicate safety? And so you may think about every detail of your unit and how it does that. Choice And this is also very interesting, in that we want to provide people choice as much as we can. It's interesting in the fact that sometimes in hospitalization, psychiatrically, people are there against their will. So sometimes people take that at liberty as staff and say, because of that, and because they're not feeling well and maybe they're experiencing psychosis, that means that we should make all these decisions for them. And actually, it's not that way. We need to offer people as much choice as we can. So they may be involuntarily hospitalized, but we still within that need to offer them as much choice as we can, respect their autonomy and their agency, and give them a feeling of control, because without that control, it can be traumatizing. One of the things I love to do is let people know what their Bill of Rights are on inpatient settings, and also give them the number to Connecticut Legal Rights Project. So that can actually be a lawyer that works for you in your treatment process, so that you feel like you're being best represented and getting the best services. And also sometimes it's important to let your staff know the limitations of what it means when someone is conserved, because they may take that liberally. And not probably from a poor intended place. They just think maybe that person may not have the ability to do it. But actually, we need to let people know that we need to honor as much choice as we can. Collaboration, of course, this is about power sharing and us working with people in the decisions that are for their life, right? It's not about us making decisions for them. And then being trustworthy. When we say we're going to do something for someone, we do it. We come through that. We are who we say we are. We are trying to provide a healing environment, that we respect people, that we respect everybody's culture, race, ethnicity. We respect their gender identity. We respect who they are. We're good with boundaries, and all the different ways we communicate that. And we empower people, so it's super important to think about how we're empowering people, validating their experience, and helping them be a leader in their own healing experience. And this is really important because so many people have experienced trauma, and if we're not careful, we only add to the layers of that trauma when they come into an inpatient setting, when some of their rights are taken away from them by the very idea that the door is locked. So we have to be really thoughtful about this. One of the other things that I really think is so important is the idea of offering recovery-oriented care in our services in inpatient settings. And please ask a question, as we said, along the way, if you have any questions about any of this. And I just listed some of the 10 basic ideals of it, or tenets of recovery-oriented care. But the whole idea of recovery-oriented care is not necessarily just what we think about when you think of recovery, like from substances, but this is coming out of the mental health movement. And this is when people who were living with lived experience of mental health concerns said, hey, we want to no longer be seen just as patients. And this is out of the consumer movement, and we shouldn't be defined by that. And this is when the survivor movement happened, and a lot of people went back to the community. And from this perspective, we really try to see people beyond the diagnosis and see them as people who have the right to live a life of meaning with the goals they want. And the tenets are beautiful. And so we try to think about, how do you develop an environment that shows that offers that in every way, strength-based. So we're supporting people from the things that we see that are strengths. We're not just listing all the things that are wrong with them, all their problems and all the symptoms we need to eradicate, what are the things that make them talented, and how can we build on that? How can you integrate peer support, so people that have also lived experience and can support them? How do we offer respect? So if we want respect from people that we're offering services, we need to show respect. We need to model that. How do we help people take responsibility in their own journey? We not just doing things for them, but we're in the role of helping people take personal responsibility. And how do you offer hope? I think it's an interesting story to share about a woman I worked with that had spent about 15 years of her life pretty much in straight long-term hospitalization with only a few weeks out. And she came to my setting, and particularly to get positive behavioral support here, because they knew we could do it. She had a lot of serious history of suicide attempts, non-suicidal self-injurious behavior, and also harming some other people, and had done some time in prison. and really came to us without much hope. She was maintained on basically a one-to-one with concern that she might hurt herself. And we worked and did all these amazing different savvy plans over many years, which were very effective, I have to tell you. And I helped lead that. But when people ask me, what did you do to help make such a significant change in this person's life? And the change is that woman now, after working and knowing this woman for over 9 years, she had 3 successful years out of the hospital and continues to only have small term hospitalizations. But the biggest thing I tell people that we did is we offered hope. There's significant moments along the way where she would get mad and say, you guys just need to give up on me, send me to the state hospital, let me be locked away forever, and give up on me. I'm a monster. She would say things like that. And, you know, we would look at her and say, no, we believe in you. We actually have taken data on the last year of your life, and you continue to keep improving. And although you're having a really hard time now and you're feeling really suicidal, and I can't imagine how hard that is, and you're feeling like you want to die, we still have hope and we believe in you. And I can't tell you how much those conversations, I think, were pivotal moments in her life. And now this person is someone that I think of when I think about, like, I'm passionate about what I do. So offering hope is so important. And, you know, these other things are important: self-direction, person-centered care. So what are this person's goals? What do they want for their life? It shouldn't just be about, like, this person needs to take their medications, show up at their appointment, and go see their therapist, you know, be a good patient. No, you know, this person wants a girlfriend, they want a job, they want an apartment, they want to travel. So how do we start there with what they want? Or we have no you know, way to reach them. We have no way to work with them, you know. So all these things are important. Another really important thing I want to point out is the nonlinear journey. It's so important, I think, to emphasize the fact that it's not straight up like a mountain, you know. We may have a few steps forward and then a few steps back, a few steps forward, a few steps back, and then we may move 10 back. But realizing that recovery is happening all along that way, no matter how many steps forward and how many steps back you go. Another really wonderful thing that we're trying to do now, and that psychologists, I think, really can bring to these settings, is our knowledge of evidence-based practice, and in so many varieties of ways, whether that's specific psychotherapy interventions, specific you know, ways that we provide services, you know, all these different types of things. So we are really highly trained in this. As many of you know, this can really heighten the caliber of services that are offered. I'm in the public sector, so to me, it's also a social justice advocacy issue that, like, when I got here, I can't tell you one really strong evidence-based practice that we were offering, but yet we had people with really complex concerns they were experiencing, and there's these practices out there that I knew would really help them. So there was this science to service gap and this equity gap on my unit. And since then, we've done some phenomenal things with being able to offer a lot of these things you see here on the right, like DBT, ACT, you know, CBT for psychosis. We do some trauma interventions. I also offer positive behavioral support, which has just been phenomenal and helped change the culture. So that's basically when people have challenging behaviors on the unit, we see them and we try to understand them and understand what the person is trying to communicate, and seek to build skills on the part of the person and the staff so that we can help them decrease in having that behavior, but also move towards a life of meaning, and also not use coercion or any punitive measures. Another really important thing is, you know, as many of us know by now, we're really highly trained in cultural awareness and responsivity. So a lot of units I find haven't been highly trained in this, and it doesn't mean that they don't want to be. I think it just hasn't been offered in many of these settings. So how do we bring that there? How do we help them? Something we're really working on now in our unit is working on anti-racism and looking at our policies and trying to understand how we can make them come into more of an actively anti-racist congruent manner. We can provide training, education on this, work as advocates in every which way, whether it's getting involved when you see something happening on a team, speaking to your mental health commissioner about something. So we can lead in these advocacy ways. We can also integrate our knowledge of intersectionality, right? This person comes to us not only with schizophrenia and their experience of it, but they're also experiencing deep poverty, food instability, they're experiencing racism, sexism. So how do all these intersectionalities work together to build a more fused experience? And how do we understand that, and how we treatment plan and work with this person effectively? And one of our also, I think, things that we can be most talented at is helping build skillfulness and effectiveness of a unit, of the unit as a team, in training in these areas. How do we, I know that we've worked with people that have diverse gender identity, and some people really didn't have great training in that and didn't know how to work in an effective manner. And so we really had to dive into some clinical standards for that, and best practice recommendations, and that was very helpful for us. All right, Jeff.
That was so nice, Erica. And what I sensed happening, what I watched happening in my mind as I was getting more and more enthusiastic about these 4 pillars of culture that in some ways we think psychologists have a real opportunity to bring to an inpatient mental health unit. Sometimes as a leader, sometimes you get to be the person in the chair who says, this is the way the program's going to go. Other times as an informal influence, as being the psychologist who raises their hand or makes a comment in a small treatment team meeting and says, oh, I noticed this strength this veteran has, this patient has. Oh, they mentioned they really care a lot about being more available as a grandfather. I think we can really harness that value. I really want to pay attention to his culture of origin, because I think that's interacting with how he's perceiving treatment. And so what we hope to do is take these big 4 ideas of trauma-informed care and cultural awareness, evidence-based psychotherapy, and the recovery model, and talk about, well, where does the rubber meets the road? How do those get translated into actual services? So when it comes to the provision of psychotherapy and group counseling, or even that informal consultation with a psychiatric resident in the hallway, certainly if you have an opportunity to involve a psychologist in bona fide program development and evaluation, then you can really get into the mechanisms of, do we assess for strengths on our initial intake assessment? Do we have a fitness room on the unit? Do we have enough therapeutic recreation so that we can engage people in whole body thinking? Research is really such a rare but really important aspect of inpatient mental health care. It doesn't happen very frequently. And of course, there's a really strong ethical reason that it shouldn't happen very frequently. People are on a locked unit. They can easily have the perception of, oh, maybe I can curry favor if I get involved in your research. So you have to be very careful, but it's also true that it's really important to understand what happens on inpatient mental health. How does that impact later outcomes? And we'll see in the final slide that psychologists have been shown to have some efficacy in the research. It's just kind of diffuse. It's kind of hard to know what mattered. But I think, these 4 pillars, these themes of trauma-informed care and cultural awareness, and using a host of empirically grounded evidence-based psychotherapy interventions, along with the richness of the recovery model, I feel like we're onto something. Measurement-based care, of course, is difficult to implement on inpatient mental health. You have to have the time, and the team needs to care about the measures. And so whether you're using short screeners or doing post-therapy measures like the PCL5 to measure trauma symptoms, that's another real opportunity for psychologists to shine. As we said, the training and leadership aspects of a psychologist's role in inpatient mental health, we think are especially poignant. It is an incredibly joyful moment for me to have practicum psychology students every year and have them circling back and telling me how they're experiencing the team, and for me to know that they are one of those flag bearers that I explicitly say, when you go to a treatment team meeting, we're expecting you to be the person who reminds the group of strengths, who helps the group see a trauma history, and who really holds, as Erica said, that non-judgmental perception on nonlinear. that folks sometimes do have successive rehospitalizations as they're learning in this big arc of their recovery how to be well and how to manage their symptoms. And of course, the incisiveness of positive behavioral support, that's the place, another place where I think psychologists really shine. I think if I had to guess what comes really naturally to Erica when she helps a team break down a behavioral chain analysis and look at reinforcement value, feels like magic to the other people when they see the behavior change, when they see that little places of praise, little places of reflecting or of describing the desired behavior can be very powerful. And of course, when that's done in a humanistic way, that's what we're all here for, is to blend those things. Next slide.
So now we were also going to add in something that was a unique leadership opportunity for psychologists, is the role we held in the COVID crisis. I don't have to tell you all that hit us all like a bomb. It was traumatic. It was, for the whole globe, but in inpatient care, it was especially stressful, I have to say, because overnight we were like, oh no, how are we going to manage this? And how are we going to keep the people that we're providing services for safe, literally, like for their life, so this took a lot of, I think, courage from a lot of people, but it was really interesting in many ways. Is a lot of psychologists, I think, and I also over Division 18 connected with a lot of psychologists that were doing this overnight. We were developing policies with our colleagues about how do we keep everybody safe? Like, how are we going to manage the fact that we have way too many people in the unit at once, right? And so we changed the way we do shifts, we changed the rotations of everybody, and this is practically all in 1 week, right? And over weekends, and writing policies, and how do we change the way we offer groups, the fact that we could be spreading this and we could be spreading it fast, and also the fact that we may have people in our unit that have medical comorbidities that make them at unique risk for COVID, so this was
Erica, may I ask you a question?
Yeah.
I'm curious, as a point of comparison and to paint a picture for our audience, are patients in your hospital wearing masks, and have you reduced group sizes for social distancing?
I love that you asked this. Because so when it first started, people weren't at first, right? They were even like, we had a meeting as happened in our whole nation, right? Where people at first, we didn't think we needed a mask, but then, we learned pretty quickly we all need masks. But honestly, it was incredible how fast people were able to learn from education and wear masks. I would say we had probably 90% of the people very quickly all wearing masks. Of course, the staff had to, as part of just being on the unit, but we also were able to provide education of the importance of it, and do it in a way where, I think people were honored and respected. And we were also thinking, how are we going to get people to do this? Because people have different ideas, especially when they're experiencing psychosis. We did fun things and creative things like offer, who's mask wearing contests and things. People made it fun, so that was neat. And Jeff, you asked me another question. I'm trying to remember what it was.
Yeah, I was just reflecting on the process we went through as well, where we were trying to figure out how can we provide information and reinforce mask wearing and safe behavior. And we found ourselves, really returning to a classic value in veteran care, which is veterans care about other veterans. And so when you invoke group safety, that can be very persuasive, but we had challenges with variability of both veteran patients and staff wearing masks, and it created a lot of strong feelings, right? So staff who have been reminded again and again, you got to pull up your mask, you got to be wearing a mask when you have an outbreak and you have some staff members transmit the virus to other staff members, some who were wearing masks and some who were not as vigilant, then I was just aware there was kind of strong stressful reactions. And we never wanted to go to a punitive side, right? Where, you're going to get written up because you're not wearing a mask, but we just really struggled with the reminders and how to set that standard. We eventually decided, we were pretty clear patients needed to wear masks in group, and the expectation was to wear masks outside of your patient room, even when you were just on the milieu. But honestly, that was just so hard and so variable with nursing staff willingness and comfort talking with folks with acute mental health symptoms about pulling up their mask or about going to get their mask from their room. And so I just wanted to be real about the challenge. It sounds like you had some success, but also found some really nice ways to incentivize it and have fun with it in ways that sound pretty inspiring.
Yeah, I appreciate you sharing that and the complexities of it. And of course, that was when we were probably scared the most, everyone, and our patients do not wear it at that level at all now, so it's rare now for us to see patients wear it. I would say only probably, 15% wear it now, but I think there's a sense of greater safety now because of the vaccine and the antiviral. And we also similarly are less stressed about them not wearing it, though we are all wearing it, but I think you bring up also the balance of safety and protection of human rights, Jeff. Like, it has been super interesting to me, and if only a few other people have written about this, I think nationwide, but I've really had challenges from a social advocacy perspective and just wanting to speak up about the fact that on our unit, people are locked in here, and though many of us have resumed many things in our life that were shut off for us for a long time, and we get to go those places. And for a long time, we went those places and we were just very cautious and we wore masks, right? And we did it all in this deliberate way, but we still went to the grocery store. We still did this and that. And so what has happened at my unit and many places across the country is the rights of inpatients, I think, has been limited longer than if you were out in the community, right? So it's been this interesting. It also brings up, I think, the stigma we have of what does that mean? Does that mean that we think that they're more likely to get it or they're more contagious? Like, what does that mean? So we've had to bring up those things, and the fact that by not letting them have access to the community for longer, that also might be endangering them in their recovery and their wellness. So we've had some really tough conversations here about that. And then, if you are trying to social distance on a very small space, how do you still offer effective treatment? How do you still do groups? We did reduce our group size. I remember you asked that. It was smaller, so we offered more groups and shorter snippets of time. I talked to people nationwide. There are different people who've done so many different things, and one through the VA where everybody got an iPad and like groups were like cast from like one room, but everybody could be in their room on their iPad. I was like, man, that's amazing. Whereas for the longest time, we couldn't get iPads approved here, but we could use an iPhone so that people could call their families and use FaceTime, even though they couldn't see them in person for a while. So, and then of course, the complexity of continuing to provide effective training for trainees during this time is very difficult. At times they were doing rotating shifts on the unit, and so we only had so many staff on the unit at a time. Sometimes they were trying to call in and only use different technologies to do sessions, but it's less effective because inpatients are used to having people here. And now we have like a hybrid model. So it's really interesting, but I would just say this brought up for me the fact that when crises come out, we are good at being flexible and helping think creatively. And it's been beautiful in that way of thinking overnight and helping make changes overnight. Also, making changes and engaging in advocacy related to things that need to shift to be able to offer mental health services. And then, I just think of the strong role we play in learning and knowledge and providing education on units. There's just a great diversity as far as the amount of training people have. You have people that are mental health assistants that are there spending the most time with patients, and they may not have had the opportunity to have as much education as some of us have. So it's a great place to offer education where we can all learn together. And then opportunity for us to learn from them, because if they're with the patient the most, they may see things that we don't see and that we don't know, that they've learned over many hours of spending with individuals, you know. But we are trained in these unique ways. We have the opportunity to offer trainings. I also realized on my unit that we had a lot of residents that were coming to the unit and expected to provide some type of psychotherapy, but they had only had 2 years of residency. So they really hadn't not that much skill level. So, and also because I, you know, have motivations to affect culture, I said, hey, let me lead a seminar in psychotherapy. And I can't tell you how much I loved teaching that resident seminar and how much they love it, because they're really, they're like sponges. They're so excited to learn it and practice it here on the unit. And then also, you know, because we're so trained in all these specific areas of evidence-based practice, new models, we bring that richness to the unit and we can get people excited about it. People want to learn and grow, you know, so it's exciting time.
That's so terrific. Thank you. Just a quick comment before we jump into suicide prevention about, you know, something you and I were talking about before, and that's the emerging neuroscience of neuroplasticity and the unique partnership we have on inpatient mental health. We're working closely with psychiatric residents. And gosh, if ever there was a buy-in to, you know, two disciplines that have an incredible yearning to understand better how the brain works, neuroplasticity and neuroscience, gives us some of that hope. So I'm really quite envious. I'd love to talk with you more about the class you gave on psychotherapy, because we found the same thing, that the students, the psychology practicum students and the psychology interns doing psychotherapy with patients on the unit are a magnet for the psychiatric residents that want to understand, well, what is the skills training you're doing in dialectical behavior therapy? What does it mean to let go of the agenda of control and open up into choosing action that fits with values that partners so well with this antidepressant medication? How can someone learn relaxation skills that really intermesh with anti-anxiety medications? So I'm really excited that maybe that's another talk someday, the neuroscience of neuroplasticity. But of course, at the core of inpatient mental health work is suicide prevention. I am now in a special assignment role to the National Office of Mental Health and Suicide Prevention for VA, and I get an email every time there's a suicide attempt or death by suicide nationally in VA. And it is like this beating drum of despair and suffering in real time. And so to me, I could spend the rest of my life figuring out trauma treatment and suicide prevention. So I in no way do I think that I'm offering some pat structure and formula for suicide prevention safety planning on inpatient mental health, but we have seen some themes. There are things that I'd like to share that I think occur with a level of regularity that we can start to rely on. Psychologists in public service, especially those in acute care settings, have this particular opportunity to innovate here. And I want to talk a little bit about the importance of joiner theory. And then again, I want to make those connections between the conceptual and the operational, both in terms of joiner theory, maybe as it shows up in psychotherapy, but also in terms of what we might call supercharged or advanced safety planning, where we're really using evidence-based psychotherapy interventions and mapping them on to the stages and steps of a typical safety plan. So many of you are aware of Thomas Joyner, one of the most famous suicidologists of our time, and his seminal work in 2005, Why People Die by Suicide. And you probably, some of you may know that Tom Joyner came to this field quite naturally. He lost his own father to a completed suicide in the family van, not too far from their family home, and his father tragically had ended his life by cutting his own jugular vein and bled out in that van. And this propelled Thomas to try to understand, how does this happen? And like many of us, Thomas was not a hypothetical deductive reasoner. He was a little bit more of an inductive reasoner. So he looked at all the suicide data, all the completed suicides, and he said, what's lawful here? What just keeps showing up? And these three core themes show up again and again. Acquired means, that is, people have to practice dying. The people we lose to suicide are people that have had suicide attempts and self-directed violence. The man who threw himself from the bridge was there 1 week before and he hauled one leg over and then thought better of it and hauled it back. People that take overdoses that are sublethal eventually work up the courage to take a more lethal overdose. And so understanding that past behavior predicts future behavior probably surprises no one in this virtual room, but it was certainly made highly valid by Joiner's work. The other two pieces are kind of a combination of perception, but also experience. And that is perceived burdensomeness, the notion that I'm just an irritant to others, and the experience of thwarted belonging. There is no group that would have me. I am alone. I don't belong anywhere. I don't fit with anyone. And you can see, I think, right away that these are rich areas for psychotherapy. You know, burdensomeness and thwarted belonging are just words that lead us naturally to ideas like reframing difficult thinking and behavioral activation. I was asked by a mentor once where I feel the greatest sense of my true self, where I feel at home. And I was telling Erica, my flow state is in a group on an inpatient mental health unit with a student present, reckoning with some of these ideas. And when it comes to what's magical and powerful about group is the ability on an inpatient mental health unit to foster shared vulnerability such that you see social connections happen right there in the room. And then you just watched a protective factor happen, right? We know that social support, feeling like I'm not completely alone, maybe I'm not just a burden, is one of the more powerful aspects of suicide prevention. And so we get excited, right, when two patients on an inpatient unit exchange numbers or find common ground or say, yeah, me too, in a group, or just start nodding their head. And we wanted to capture for you that felt sensation. That one of the reasons Eric and I love this topic and wanted to talk about psychologists on inpatient mental health units is because we get to live this. We get to see people realizing that there is an answer other than I need to die. We get to see people open up from really hunkered down, really shut down, really depleted, to being the person bringing others to group. Hey, you got to come to this group. This group is really helpful. Give it a try. And so Joiner theory allows us to really apply some science to understanding risk around suicide. It has been said, I think this is an apropos metaphor, that all of us may know ideas like planning, means, and intent. If you're there in the emergency department, you're assessing someone's level of risk, you want to know, do you have a plan? Do you have the means to actually do this? What are your reasons for dying? What are your reasons for living? And you perform a critical risk assessment. That's when the fire is already lit. If someone's in front of you in the emergency department, things are well along their way. These Joiner theory concepts of feeling a sense of burdensomeness, feeling like I don't fit in, trying to die, these are a little bit further out. They're sort of like the smoldering embers before the fire lights. And so we think it's really important both for teaching people about their own suicide prevention, but also especially for student training, that we pay attention and we just speak plain spoken language to patients. We just teach them Joiner theory, right? And we ask veterans, where are the places where you have felt a loss of belonging? And for, as you guys can imagine, for veterans, there was the disconnection from family and home when they went abroad, and then they come back as veterans, and then they disconnect again from that core unit. And so, and talk about acquired means, although in this country, many people are trained on using lethal means like guns, certainly veterans have an even heavier loading of that kind of training, of familiarity with our most lethal means. So psychologists on inpatient mental health unit are uniquely able to articulate these things in groups and individual psychotherapy and in consultation in ways that can really matter. And when I talk about mapping evidence-based psychotherapy concepts into robust safety planning interventions, I was careful about my words there. I didn't say mapping it onto a safety plan. I said mapping it into safety planning interventions. What we don't want is a safety plan to be a piece of paper that you have to fill out in order to discharge from a mental health unit. What works a lot better is if it's a fluid document and I go to a group and I learn a new skill and then I look back and I add it to my safety plan. What we teach students is that the first stage of safety planning, that is where we are just recognizing warning signs and triggers that we may enter into a crisis, this is just fertile ground for teaching mindfulness, right? It starts as reflection. You know, how did you end up on the inpatient mental health unit? Well, I stopped taking my meds and I was isolating and I stopped picking up my phone and talking with any of my friends. And then I started to drink more and then I started to think more and more about suicide. And then I called the crisis line and now I'm here. So that's reflection, right? This behavioral chain analysis of looking back at this happened, then I thought this about it, then I felt this about it, then I did this. And what we teach people is reflection is just practice, the practice behavior away from becoming mindfulness in the moment. And what we hope people do is catch themselves going, oh, okay, I wrote this down as my warning signs. This is when this kind of hopeless thinking shows up. It landed me on the inpatient mental health unit last time. This time I want to make a different choice. And so psychologists who are training people in mindfulness on how to watch our minds or how to regard a thought as just a thought are dancing right in these grasses, and they're able to help use concepts like what we might call the observing ego, right? Or what we might call metacognition, and apply that to the safety planning intervention of knowing your warning signs and triggers. Then, of course, when you get into dialectical behavior therapy skills and you're teaching people how to distract and you're teaching people how to practice wise mind, those map right on to levels 2 and 3, things I can do on my own to cope and move through a tough time. And then you get further down the safety plan and it starts to talk about lethal means safety. Can you put some distance between you and the medication? Can you put some distance between you and the gun? Could you even put this safety plan on your gun locker so that you remind yourself of your reasons for living before you acquire those means? And so now we're into being very specific in terms of behavioral prescriptions. You know, I'm going to ask you to change something in your layout so that it takes you longer time to access those lethal means. And so we think psychologists are really well suited for articulating these ideas and for engaging with them with a level of enthusiasm that really seems to matter. Next slide. So it wouldn't be a presentation if it didn't have PowerPoint slides, and it wouldn't be a presentation if we didn't have research article links. So we did a little research and we found some things that are not too surprising about inpatient mental health and psychology. The number one thing that I hope we all get to feel proud about is it seems to matter. It seems to work a little bit. So in the first article, we could see that therapy was associated with some reduced readmissions and some longer term effects around depression and anxiety. It was just really hard to nail down exactly what the mechanism of action was there. But there was a strong correlation, one that was statistically significant. The other main finding from the second article is that, as Eric and I said, psychology is seen by a multidisciplinary team as integral, but not often the first line treatment, right? The docs are prescribing the meds, the social workers are getting that discharge disposition lined up, getting some resources connected. And in many systems, psychotherapy or groups are something added on. Certainly at our VA, you can stay in your jammies the whole time, never go to a group, never do any journaling, and just accept the medication change and keep saying, I won't kill myself until we have to let you go. And we talk in very direct ways with patients about how much they're going to dig in, and that patients have a choice. You could do as little as possible in an inpatient mental health unit with that arms crossed posture, or you can really dig in and get into journaling and exercise and psychotherapy and talking with a peer support specialist and doing therapeutic recreation and talking with a chaplain. And then all of a sudden you're intervening like all these spokes of a wheel, not just medications and structure, right? And TV, but getting involved in groups and practicing emotional journaling or practicing mood monitoring or getting on the phone and asking for forgiveness or giving someone else forgiveness. And so that behavioral activation part is the place where psychologists can really shine, because they may never be integral, or they are integral, but they may not be first line. So teaching psychology students how to say, I have an idea about how we could help this patient, is a way to kind of move that line just a little bit. It has been shown that embedding evidence-based psychological services has the potential to promote high-quality, well-rounded care that aligns with the established mission of multidisciplinary teamwork on integrated medical and psychiatric inpatient units. So this is the article that said more research is needed. We can see that psychologists on inpatient mental health units are highly efficacious, but there's so much variation, right? We don't have some standard practice. When Erica and I were exchanging notes, it was sort of like, oh, you get to do that. Oh, we do this thing. Oh, you have that kind of group integrated with peer support. What, you have a recovery library and you give journals. So it's really hard to compare subtly different environments and say something definitive about the power of psychology or psychologists on inpatient mental health. So, to summarize, no surprise to us, more research is needed, but what is there is very promising and leads us to see that we're really on to something here. All right, last slide.
All right, I haven't seen any questions come through the chat, so maybe while we're waiting for folks to pop them into the chat box, I was wondering, Eric, I think you mentioned the role of peer support at one point, and I was just wondering what peer support looks like in both of your settings, and certainly if folks have other questions, we have about 10 minutes left for our presenters.
Absolutely. I love that you asked that question. And man, peer support, I can't speak highly enough about peer support, but just so in diverse ways, and I'm sure it looks different for Jeff in the different sites, but for us here, it can be such a thing as when we think someone might benefit from working with a peer support, we ask them, hey, we have peer support here at CMHC. Would you be interested in meeting with someone from peer support? And, sometimes people say yes, sometimes people say no. And sometimes people say no, but then later on say yes, so, but we allow that to be also then from that perspective, collaborated from and developed between those two people. So the peer support then comes to the unit, meets with the person, and they decide together what they want to do together, whether they, want to meet every week and just chat, or they have plans that they want to, go out on, an outing and go to the park and, go talk and do something there. So it can look very diverse. Or we sometimes have peer support that help people come in and think about some of the things they want to do with their life. Like they want to get involved in the community with hobbies. And so maybe they go with them to a poetry slam or something like that. So it can be very diverse, but I would have to say peer support has been really integral in helping people with, both people with lived experiences and help those that are in the hospital at the time be able to imagine moving forward, having hope, and moving out of the hospital.
Yeah, thanks for the question, Josh. I've had the unmitigated pleasure of co-facilitating our trauma recovery group with our peer support specialist, Mackenzie Carey, for the last 6 years. Mackenzie is a Vietnam-era veteran who has a lived experience of trauma recovery, both from military sexual trauma and from childhood sexual trauma. And I joke that although we're both in the room, everyone's eyes are locked on her once she starts telling her story. She's the most important person in the room. And we've developed a convention over the years that really feels like I'm lobbing her softballs anymore because she hits the ball so hard. It'll go something like this. Hey, Mackenzie, did you ever have an experience in the darker days of your recovery where your vigilance around trauma was really getting in the way of living? And then she talks about checking doors and windows until 3 in the morning every night, and that she couldn't trust her mind that she actually locked that window. And she has one of the most powerful statements that you can hear on an inpatient mental health unit from a peer support specialist. She says this: She says, back in 2010, I tried to kill myself 6 times in 7 days. And I ended up on the inpatient mental health unit, and I didn't want to be there. And so I didn't go to groups. I didn't do anything. My arms were crossed. I just said, leave me alone, go away. I'm not going to kill myself. Let me go. And when she left the inpatient mental health unit, she looks back and says, I left too soon. I was scared silly that weekend, and I wished I had stayed. So when she tells that story, you can see, right? You can almost feel how that helps people open up, because she can look in their eyes and say, don't do it like I did it. Like, dig in, take a risk, open up. So that's a really important question, because peer support specialists cut through all the psychologist mumbo jumbo. Mm-hmm. So what you and I might call cognitive reframing, she learned a simple phrase of saying, catch it, check it, change it. Catch the thought, check the evidence, change my relationship with that thought. And that's just going to ring in people's ears a little bit nicer than cognitive reframing or cognitive processing therapy, I hate to say. So I appreciate the question. It's such a lovely place to end, on one of empowerment and recognizing the incredible potency of our peer support partners.
Looks like we have a question from the audience. Can you speak a bit more to building resilience practices for staff and patients during the pandemic? What recommendations do you have for those of us wanting to build resilience?
Go ahead, Eric, I'll let you start.
Wow, what a phenomenal question. I think you first have to start from a place of just extreme validation. And so I run a weekly behavioral meeting, and throughout the pandemic, sometimes it's a place where people come just to be heard, right? And they have dealt with so much, and then now they are worried for their families and have to come in and work with a lot of people. It's better now, but it was very scary for everyone, right? And then be effective. They're hoping people are managing well and feeling okay, so that they don't have to put hands on people. We really do that very rarely, because we really have worked really well with people. But I would just have to say, building resilience and working through the pandemic has first acknowledging what people have been through, validating it, speak it, and share such deep appreciation. I think we've had to just offer spaces also for people to talk about it. So weekly, sometimes that's what I've been doing in my behavioral meeting, is also just checking on staff, because it's been such a grind, and it's been traumatic, and I've named it as traumatic, right? It was for me. And still is a trauma that we're all recovering from. So naming it, allowing spaces for people to process it, expressing appreciation for what people have done. I think, pointing out when people are doing amazing things when you can, offering, I think acknowledgement, rewards for people, or I think the most, I think more than a gift card or something like that, people acknowledging like the impact people make. So even like the biggest thing people really love is like that acknowledgement, like a little award that says, during the pandemic, so-and-so did this, so-and-so would go and get this so we could protect people. We had 50 people make masks so that we could all have a mask, So I'm gonna hand it to Jeff.
Yeah, it's so funny. I was getting chills while Erica was talking, because we never covered this, but it turns out she and I did the exact same thing. I had a standing recovery development work group for program development, where mostly we're about enhancing the programming and talking about volunteers and talking about new groups and those kinds of things. And during the pandemic, it absolutely transformed into let's show up as humans, let's be as authentic as possible, let's be real with each other about what's scary and what's working and what's hard. And the feedback I got is that was so appreciated, and that folks were then looking forward to even more the Friday morning session, where we might do a mindfulness exercise, we might do a body scan, or we might just show up and check in. Hey, how are you all doing? How are you carrying this stuff? And to be very honest about the sheer amount of uncertainty in our lives between climate change and the pandemic and political divisiveness and active shooters in this country, people can feel frayed, like very thin. And so to just call it out and say, it's okay, we're all scared together, but at least we can connect, has felt really powerful. So it's a terrific question from the audience. I really appreciate it.
Yeah, thanks, you too. I think that message of resilience for everyone on the call and everyone who's going to listen to this afterwards is a great note to end on. So I want to thank both Dr. Carr and Dr. Smith for joining us today. I put some information on getting your CEs into the chat, but feel free to be in touch with us if there's anything else. And thank you, everyone, and thank you to our presenters.
Thank you. My pleasure.
Thank you, everyone.
Erica, you should be able to click the little stop record button at the bottom.